Hey everyone, today I want to talk about a case of idiopathic intracranial hypertension. So this is an MBOS question, and I want to talk about it a little bit. So let's just read the case. A 31-year-old woman comes to the physician because of headaches and nausea for 2 weeks. The headaches are worse on awakening. She cries in a 7 out of 10 intensity each period. She has noticed brief episodes of visual loss, both at several seconds, especially when she suddenly stands up and bends over. She's 165 centimeters, 5 feet 5 tall, weighs 98 kilograms, BMI is 36 kilograms. The vital signs are within normal. The examination shows a visual acuity of 20/20 both eyes, mild peripheral vision loss. Fundoscopic examination shows bilateral optic disc swelling, and an MRI of the brain shows no abnormalities. A lumbar puncture is performed, and opening pressure is 310 millimeters of water. The CSF analysis shows leukocyte count of 4 millimeters, 4 cells per millimeter cube. Protein concentration of 35 milligrams per deciliter, glucose concentration of 45. Which of the following is most appropriate next step in management? Okay, so this question describes idiopathic intracranial hypertension. You might know it as pseudotumor cerebri, but that's really the old terminology for it. So the more appropriate wording for it is idiopathic intracranial hypertension. As the name implies, this is just intracranial hypertension that is idiopathic. We're not really sure why. Now, the majority of cases occur in obese women, middle-aged obese women. And that's really what the case is describing here. Now, that can occur in children, of course, that can occur in men, but that's what the majority is, and certainly in exam questions, the vignette will describe an obese middle-aged woman. So, and the other thing is that this headache, especially when she stands up or bends over, shows visual loss, that's a feature of intracranial hypertension. Because when you're moving around, that's a change of position. You get symptoms that the headache might also fluctuate with the change of position. Also the BMI is 36, that's an obese woman. And the vital signs are normal. The hallmark of a patient with headache, when you're approaching a patient with headache, the hallmark of idiopathic intracranial hypertension is papilledema. And that's very important because that's otherwise, if there's no papilledema, you wouldn't really consider idiopathic intracranial hypertension as a cause of the patient's headache when you're approaching, because obviously when you're approaching a patient with headache, you would perform a neurologic examination, a brief neurologic examination, and obviously some history, and you would do a fundoscopic examination. And what you're looking for is papilledema. Now, when you see papilledema, obviously you consider other things, but one of the things you consider is idiopathic intracranial hypertension. Now, there are cases out there where there is asymptomatic idiopathic intracranial hypertension, so they don't really have headaches. So how do you diagnose that? It's just the routine fundoscopic examination that they perform, and they found papilledema. And they found no other cause of elevated intracranial pressure, and that's how they make the diagnosis. So you wouldn't really diagnose it otherwise. It's just screening and you found it. The other things that I wanted to talk about, the CSF analysis here is normal. The MRI is normal, but the opening pressure of the is very elevated. It's elevated. There is some vision loss. Now, it used to be called like benign intracranial hypertension or something else, but that wasn't very accurate because there's nothing benign about that. One is that the headaches can be very debilitating, and two, there is a risk of vision loss if it's left untreated. So nothing benign about that. So that the nomenclature of idiopathic is better than just calling it benign. So you want to treat that because you don't want to risk vision loss. So that's the main complications, and I don't know if they want to actually about that, but in real life that's the main complication, is that the patient might suffer visual loss because of this hypertension, intracranial hypertension. Another thing that I want to point out is that, interestingly, some patients have transverse venous sinus stenosis. Now, whether this is a cause or an effect, we're not really sure, but there have been some therapies in which they perform transverse venous sinus stenting. They put a stent there, sort of like the ones you put in your coronary arteries when you perform PCI. And they have been showing promising results. So in the future, this might be a treatment modality in the future. We're not sure yet, but it's still experimental. The other thing that this is usually associated with is medication, especially vitamin A, tetracyclines, and like other medications, but that's usually what they're going to describe in terms of examinations. So you want to ask about drug history. They can just describe a patient with acne. They wouldn't have to tell you that she's taken like some sort of vitamin A derivative. They just describe, say, she has acne. Or they could just plain out tell you that she's taken tetracycline, some other acne medication. And really, that's how you make the diagnosis. You'd have a normal MRI, an elevated opening pressure with lumbar puncture. You would have no other abnormalities. You might see some venous sinus stenosis that can be seen, but you would have found another cause, like a tumor or something. The treatment, the first line is acetazolamide therapy. That's the answer in this case is acetazolamide. That's the treatment. But not all patients respond to that. There are other medications they can. This is a carbonic anhydrase inhibitor, but if they usually respond to that. We also would tell them to lose some weight. Weight loss have been shown to improve the headaches and the whole intracranial hypertension thing. So weight loss, acetazolamide therapy, and you would do some medications. Other than that, I doubt we would actually be asked about that. But there is a role for surgery, and as I said, transvenous science stenting, that is still experimental. But what else they can perform is optic nerve sheath fenestration. This is the answer C. That's not the answer in this case because you would not go immediately into surgery. And my understanding of this is just put a bunch of holes in the optic nerve sheath so that the pressure will be relieved and you wouldn't get that much pressure on the optic nerve. Because really that's the whole reason why we want to manage this condition, because of the risk of visual loss and optic nerve damage. So I hope this has been helpful for you guys, and please like and subscribe. Thanks for watching.